So Dr. Alex is the Director of Education and Training at the Fenway Institute, and is an Associate Professor of Psychiatry at Harvard Medical School. Some of you may have met him when he came over to the Philippines to visit some sites, and I'd like to welcome him back. Hi, Alex.
Hi, Dr. Kate. I'm not sure if I'm visible yet. Can you hear me?
We can hear you. Yes. We'll
Great. Can you see me?
No, hold on. There. We should be able to see you now. Yeah, we can see you.
Excellent. Great to see you, Dr. Kate. Hi, everybody. Wonderful to be here with you all. So exciting to see the Mental Health Learning Collaborative Learning Network being launched today. Thank you so much to our friends and colleagues at SHIP, at UCSF, to PEPFAR for their support. As Dr. Kate mentioned, I was fortunate to spend a very special week in the Philippines, in the Manila area in May of this year, and was able to visit several HIV care sites in the area, to meet with leadership, to meet with care teams, providers, service staff on the ground. And it was a wonderful education for me and gave me a lot of insight into what the aspirations are of our HIV care staff in the Philippines and where we are now and where we would like to go. I'm going to be sharing a bit about mental health integration into HIV care, and I'm going to share some slides to do this. This is a somewhat broader vision for how we can integrate mental health services than the specific quality measures that we're going to be focusing on in the learning network with you all. But I think this provides a bit of a North Star in a sense of the range of things that are possible. And obviously we'll be much more focused and specific in the work that we do within the network. I'm going to talk about some effective approaches for integrating psychosocial mental health services into HIV care, how we can use resources that already exist to address mental health needs of clients living with HIV, and also in this context, how we can apply principles of trauma-informed care within HIV care services. We'll talk about that as well. Here's a framework that we find very helpful and use increasingly in our clinical care and our research and our policy work related to mental health and mental health care for people living with HIV. The idea here is that people living with HIV experience extensive stigma, discrimination, mistreatment. This is really the connection between the stigma network in many ways and the mental health network. We think of all this as external stigma-related stress. It's often the double stigma of living with HIV and having a minoritized identity, for example, being an LGBTQI+ person or a member of another key population when it comes to HIV. Or it can be the compounded stigma of living with HIV and having a mental health diagnosis and mental health challenges, for example. All this external stigma-related stress for many people over time can take a toll, can contribute to disruptions in certain general psychological processes like coping skills, emotional regulation, interpersonal relationships, having difficulties in interpersonal functioning, having certain beliefs that are understandable when someone experiences chronic stigma and discrimination, but that can perpetuate distress over time, like believing it's never going to get better, nobody can be trusted, no one will ever love me, for example. And all the external stigma-related stress can contribute to internal stigma-related stress, internalized shame about one's HIV status, for example, or around being a gay or bisexual man or a transgender person. And all of this contributes to what we see in the research with people living with HIV, which is a higher prevalence of various mental health problems. As we'll discuss, depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders, for example, decreased self-care, decreased engagement in healthcare, including primary HIV care or mental health care, in the context of a lot of medical mistrust of care providers as well. And down the road, a higher prevalence of various physical health problems and worse HIV-related health outcomes as well. Now, it's important to think about this as a stigma and resilience framework in many ways, that this can present as a crisis. It's also an opportunity to promote resilience and cultivate adaptive coping skills, which we'll talk about as well. There's a much higher prevalence of mental health problems among people living with HIV than there is in the general population. These are data from the US, for example, showing 75% prevalence of depression among people living with HIV, 70% prevalence of anxiety disorders among people living with HIV, and 80% prevalence of post-traumatic stress disorder among people living with HIV. And these are, again, data from the United States showing that among people living with HIV, only a certain proportion, not everybody, actually received an HIV diagnosis. Of those people living with HIV, only a certain proportion were ever screened for depression. Of those screened for depression, only a smaller proportion received a depressive disorder diagnosis. Of those with the depressive disorder diagnosis, an even smaller proportion received actual treatment for depression, right? So it ends up being a small proportion of people living with HIV who are screened for a mental health problem, diagnosed with a mental health problem appropriately, and connected to treatment appropriately for their mental health problem. Mental health problems among people living with HIV can contribute to non-adherence to antiretroviral medications, disengagement from routine HIV medical care, increased risk for substance use disorders. Speaking to colleagues when I was in the Philippines, it sounds like some of the main substances we see there are alcohol as well as methamphetamines, for example. Inconsistent use of condoms and other high-risk behaviors for transmission of HIV as well. What can we do as HIV care programs for this? Well, we can provide regular screening using validated screening tools for mental health problems. When someone has a positive screen for a mental health problem, we can link them to a mental health professional for more thorough diagnostic process and for treatment. We can provide support for a treatment plan and also follow up in this regard. I'm going to talk a bit about mental health service integration into HIV care. There's a wonderful paper that was published a decade ago that outlined the continuum of mental health service integration. There can be coordinated care, co-located care, and integrated care. Okay, and we're going to go through the different levels of this now. So if we start with coordinated care, this really involves separate systems and separate facilities between HIV medical care and mental health care. These two systems will only communicate based on issues that come up on an ad hoc basis. In what's called level 1, there's minimal collaboration at a distance between these separate systems. Level 2, there's basic collaboration at a distance. And again, only when an issue comes up reactively, not proactively. Then if we move to co-located care, that's level 4. There's some basic collaboration at the same site, same facility, but still very different systems for HIV medical care and mental health care. Then we move up to level 4. There's close collaboration on site with some integration of these two systems, HIV medical and mental health care. Same facility has some shared systems across both. It's mostly the interaction is driven by complex patients, but there's more regular face-to-face interaction and some basic understanding of the two cultures across HIV medical care and mental health care. And then if we move to really integrated care, there's level 5, close collaboration, approaching a fully integrated practice, the same facilities, some shared space, moving towards this really being one team rather than two separate teams for HIV medical and mental health care. And then at level 6, it's full collaboration in a transformed and merged integrated practice, sharing all the same space in the same facility. It's one integrated system of team care with roles and cultures that are fully blended. So that's the North Star, that's the end goal, right? Now, if we use depression as an example of a mental health problem that we can screen for with people living with HIV, it's in many parts of the world thought to be the most common mental health challenge that people living with HIV experience. People who are depressed are less likely to follow healthcare advice and to take their medications as directed. So we can make a plan as an HIV care practice. We can educate our staff to develop support. We can address the impact of HIV and mental health problems that create stigma and related challenges for our clients. We can discuss how our staff and our agency can confront the various barriers to addressing these mental health problems, right? We can decide how depression screening will fit within our current scope of services for people living with HIV. Where does it fit in your client flow? It's a question we can all ask and slightly different answers for different practices. How will we respond to a positive depression screen result once we implement screening? And how can we identify new depression resources? Is that possible? And how are we going to put those into place? We can start screening. We can add depression screening to routine client flow. We can train our staff in the use of screening tools and where these are going to fit into your client flow. We can consider a quality improvement project to guide us through the process, right? Which is the beauty of this learning network that we're going to be doing together. Here's a very commonly used screen. This is the Patient Health Questionnaire 2-item instrument. It asks about 2 symptoms of depression over the last 2 weeks, how often you are bothered by any of the following: little interest or pleasure in doing things, feeling down, depressed, or hopeless, scored from not at all to nearly every day. If the score is 3 or higher, then the recommendation, as it happens, is to administer the PHQ-9, the Patient Health Questionnaire 9-item instrument. This 9-item instrument can be self-administered, can also be clinician administered. The staff administering it, if it's done that way, doesn't have to be a licensed clinician. Any staff member in the practice can be trained. Conservatively, generously, we say it takes 3 minutes to complete. It really is much quicker than 3 minutes in reality. And you would complete it at each visit to measure depression symptoms, quantify those, and then you can track improvement in depression symptoms, decreases in depression symptoms from one visit to another. That's at least how it's recommended to do this in an integrated practice. So here's the PHQ-9, covers the 9 major symptoms of depression based on the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. And then it's very straightforward how to score this PHQ-9. Basically, the range is, if you have a score of 0 to 4, then there's no or minimal depression and no further referral or treatment is needed, all the way up to 20 to 27 as a score. That's more severe depression that requires immediate initiation of treatment, essentially. And we can, over the course of this learning network, talk about what the possible treatments are and the ones that are available to you all in your practices. You want to think about how to set up depression resources, identifying either internal services where your practices or external referral relationships that might be possible. And we heard a lot of good ideas in May when I was in the Philippines already. We can evaluate care options, decide whether to incorporate them within your facility or to develop these external partnerships. And depression is, very common. That's what we often think of when we think of mental health problems. I'm going to challenge us a bit to think expansively, and we had some very robust and profound discussions when I was in the Philippines, when we were on site visiting HIV care practices, about trauma and post-traumatic stress among people living with HIV as well, which is very common. This results from a single or recurring set of events or experiences that cause serious threat, loss, or harm to the individual, overwhelms our adaptive coping skills, can have lasting adverse effects on our functioning, our mental, physical, social, or emotional well-being. So this is very important. According to the Substance Abuse and Mental Health Services Administration in the federal government in the United States, a trauma-informed service organization is one that realizes the widespread impact of trauma and understands potential paths to recovery from traumatic experiences, recognizes signs and symptoms of trauma in clients, staff, and everyone involved in the system, responds by fully integrating knowledge about trauma into policies, procedures, and practices. So this is really ripe for quality improvement processes. And it seeks to actively resist re-traumatizing people involved in the practice. Trauma-informed approaches involve a trauma-sensitive practice environment. We're trying to ensure a sense of psychological safety and interactions with staff members for clients. Identifying trauma and its effects, the ways in which trauma can actually lead to non-adherence to treatment and various high-risk behaviors. Involves education for patients and clients about the connection between trauma and its negative mental and physical health outcomes. Often people don't realize this past traumatic thing that happened to me is actually what's leading to my worst mental health, to my physical health problems, my lack of antiretroviral medication adherence, for example, and linkage to suitable resources and referrals. Some people with traumatic experiences, many with HIV, develop post-traumatic stress. This is a psychiatric disorder that can occur in people who've experienced or witnessed a traumatic event like a natural disaster, serious accident, a terrorist act, war or combat, rape, or other violent personal assault. There are diagnostic criteria for post-traumatic stress disorder, again, in the Diagnostic and Statistical Manual of Mental Disorders. There has to be a prior traumatic event of some kind, intrusive thoughts, avoiding reminders of the prior traumatic experiences, negative thoughts and feelings resulting from prior traumatic experiences, and emotional arousal and reactive symptoms. And, we'll talk more about this in the future. This is a study I conducted over 12 years ago in the San Francisco Bay Area, where UCSF, which is involved in this learning network, is based. And we showed in this study that more severe post-traumatic stress disorder among people living with HIV was associated with higher non-adherence to antiretroviral medications. So the more severe somebody's PTSD was, with psychological dissociation and detachment from reality, the more likely they were to not adequately take their HIV medications. This really makes the case for biobehavioral HIV care, right? Integrating tailored behavioral interventions into antiretroviral medication management. There's an intervention called Life Steps developed at Fenway Health, where I'm based in Boston. This is an evidence-based intervention, and we can use these protocols, these mental health interventions, combining biomedical treatment, the current antiretroviral medications, with these sorts of manualized evidence-based behavioral approaches. But we need to screen and identify mental health problems to be able to use that in a tailored, patient-centered way. And these are often behavioral health treatments that restructure beliefs that are rigid and lead to emotional distress and worse mental health over time, and can improve HIV-related self-care and health outcomes. We want to understand that prior trauma influences reactions people have to subsequent interactions with HIV care staff. So if you're wondering why this person isn't engaging with you, often it's a mental health problem that's underlying it, and particularly prior traumatic experiences and post-traumatic stress. That kind of prior interpersonal trauma can contribute to mistrust of caretakers and HIV care staff. So we want to operate with consistent engagement that involves collaboration, transparency, trust, and communication of supportiveness to our clients. The best practice, and this is a long-term goal, not the first step in this learning network, to screen all patients for a trauma history, extra attentiveness to key priority populations that have more PTSD, like LGBTQI plus people, for example, and sex workers. We want to screen for intimate partner violence as well. And if trauma is identified, then we assess for post-traumatic stress symptoms specifically. And I won't get into the details, but there are several excellent tools used in HIV care around the world for this purpose. One is the Primary Care PTSD Screen, or PCPTSD-5. It's a 5-item screener, can be used very quickly within care settings, a highly validated tool. And initially it assesses whether a respondent has had any exposure to traumatic events. They deny exposure, that's fine, score is 0 and you move on. If they indicate that they have experienced traumatic events over the course of their life, then they ask 5 separate yes/no questions, asking about major categories of traumatic experiences. And you can then ask about symptoms of post-traumatic stress with these easy questions. And then this is easily scored, and it's very sensitive for PTSD. So this is a tool that's used around the world in HIV care. And if they screen positive, they may require further assessment by a mental health clinician. So that's where the referral piece comes in. And if we want to more thoroughly, we use an instrument that is going to assess all possible symptoms of PTSD. There's the PTSD checklist for DSM-5 or PCL-5. I won't get into the details, but I'll get to it in a moment. I should say we can also assess for intimate partner violence with very quick screening in HIV care settings. So just something for you to think about. And here's the PCL-5 I was mentioning that covers the 20 major symptoms of post-traumatic stress disorder. And this is really the gold standard instrument that can be administered at every visit to track improvement through measurement in PTSD symptoms over time. This can be self-administered or by a staff person. Again, the staff person who administers it doesn't have to be a licensed clinician, takes less than 10 minutes to complete. Really, it's less than 5 minutes in reality when you do this. Here's the instrument. We don't need to go through the different categories, but just to show you that there are 20 different items. And there's a way to score it that we don't need to talk about today. And this is really getting at what is called by the federal government in the United States, the Substance Abuse Mental Health Services Agency, the cognitive triad of traumatic stress. That trauma, which is very common among people living with HIV, affects views about the self, views about the world, views about the future, in ways that create a lot of mistrust and a lot of challenges engaging in HIV care. So we can't really, avoid this or look the other way. We need to be thoughtful about it and engage people in this way. There are great treatments, evidence-based, highly effective treatments for PTSD, like cognitive processing therapy, that mental health clinicians in the Philippines, many are trained in and able to deliver. This is developed by Patty Rezick for survivors of sexual violence initially, but can be used for all types of PTSD, focuses on education about post-traumatic stress, developing an impact statement to help the client understand how trauma influenced their beliefs about themselves, other people in the world around them, helps identify maladaptive thoughts that are called stuck points in cognitive processing therapy about the trauma that are linked to emotional distress, and allows a person to decrease their avoidance, including decrease medical mistrust, and increase resilient coping and engagement in care, for example. Just going to end with a focus on resilience here. This is how SAMHSA, the agency I mentioned, defines it. This term refers to the ability to bounce back or rise above adversity for an individual, a family, a community, or provider. Well beyond individual characteristics of hardiness, resilience includes the process of using available resources to negotiate hardship and/or the consequences of adverse events. And there are these great questions from SAMHSA, strengths-oriented questions to promote resilience. So you can say things like, the history you've provided suggests you've accomplished a great deal since the trauma. What are some of the accomplishments that give you the most pride? What would you say are your strengths? How do you manage your stress today? What behaviors have helped you survive your traumatic experiences? What are some of the creative ways you deal with painful feelings? What characteristics have helped you manage these experiences and the challenges that they've created in your life? If we were to ask someone in your life who knew you, your history, your experience, to name 2 positive characteristics that help you survive, what would they be? How do you gain support today? And what does recovery look like for you? There's this wonderful tool from SAMHSA, Resilience through Cultural, Racial, and Ethnic Characteristics. And this focuses on things like strong kinship bonds, respect for elders and the importance of extended family, spirituality and religious practices, value in friendships and warm personal relationships, expression of humor and creativity, instilling a sense of history, heritage, and historical traditions, community orientation, activities, socialization, strong work ethic, philosophies and beliefs about life, suffering, and perseverance. So these are just some of the tools that may come into play as we embark on this journey together with the Learning Network. And here are a lot of resources from our Ryan White HIV/AIDS program nationally in the United States. The first link here are for resources we created through a very large implementation project that I had the privilege of leading in the United States to implement evidence-informed interventions for people living with HIV in 4 focus areas. One focus area was behavioral health. This is a video from one of the sites in the United States where we implemented mental health integration for people living with HIV. And this is a site in Baton Rouge, Louisiana. And this is a Catholic hospital in a rural part of Louisiana called Our Lady of the Lake. So I thought it might be interesting to show you all this video of this implementation work that was done at this Catholic hospital for people living with HIV. I will just check with Dr. Kate, though, if we have time, because this is about 7 minutes, and we can watch this another time if we don't have the time.
Just as when a patient comes to the clinic to see the doctor, they have their blood pressure checked, we would like to do the same for behavioral health.
Our Lady of the Lake is one of the largest hospitals in the Baton Rouge area with inpatient and outpatient clinics. Baton Rouge, our HIV and AIDS rate is continuing to be one of the top in the nation, and mental health is one of the leading causes of chronic diseases.
So an HIV diagnosis itself can cause depression and anxiety, and it's just this pervasive worrying that they're unable to control, difficulty sleeping, low appetite or overeating, feelings of low self-worth, self-image, no pleasure, interest in doing anything. And those are the symptoms that we first recognize. We realize that pretty early on. When a patient presents to their primary care with behavioral health concerns, we will refer out to an outside clinic, and we noticed that our patients just were not following up.
Someone living with HIV, getting the mental health aspect of it treated will gradually lead to medication adherence, and we hope to lead to viral suppression.
There's different types of integrated care, and what we're doing here is a particular protocol called collaborative care. This is a protocol for bringing mental health services, particularly for depression and anxiety, to the primary care setting.
It gives a wraparound service to the patient. It doesn't add any extra burden of having to go to another medical appointment. They can come to their primary care physician, they can meet with the behavioral health provider, and if need be, meet with the consulting psychiatrist as well.
Our social workers who are specifically trained are the eyes and ears and the providers on the ground. I take the information that they bring to me from their evaluation. I also look at the chart, and then I bring all that together into a recommendation how to treat that depression and anxiety, given everything else going on medically with that patient.
When I first heard about introducing psychiatry into primary care services and in introducing collaborative care to our clinic, I was a bit skeptical. I wasn't sure what exactly that looked like.
We immediately began to have meetings. Who would actually be implementing the PHQ-2 and PHQ-9, what role each person would have in the provider, and the meetings between the behavioral health provider and the consulting psychiatrist. It's a new process, and so we met on a pretty fair, regular basis, just so that we could all get on the same page.
For about a year, we were doing breakfast and learn and lunch and learn, short lectures about what this program was about, what the role of each of the players was about.
Asia, as the behavioral health provider, she did move her office to be closer to the clinic. That way, if patients are scoring on the PHQ-9 and need to get that quick, warm handoff, she's already there on site for it to happen.
I was in a building that was adjacent but not in the clinic space, so it made it a little bit harder to reach patients while they were in the clinic exam rooms. So we moved the office because it made it easy to access patients once they were in the exam room. Primarily, we encountered some challenges regarding implementation because collaborative care only requires hands-on work from a select number of staff members. So we were just focusing on that small amount of staff members that would have direct collaborative care service delivery. However, that was we found that needed to change, and we needed to communicate openly with the entire staff because it's everyone's responsibility.
The barrier is always coming to a medical appointment. It's just something that our patient population has a high no-show rate, and so being able to have them at one appointment and seeing the behavioral health provider at the same time as your medical provider, we're hoping to close that barrier and make it easier for patients. An AIDS or HIV diagnosis, that in itself is a stigma, and if they have to take medication, additional medication to address any mental health illnesses, it's something else that they're likely to hide if it's not already out in the open. Some people do not want to take home anything that labels them as having a mental illness. And so we had to realize, yes, we roll out the intervention as it was designed, but we also had to modify it to the sense of making sure that each person's needs was met. The behavioral health provider role is kind of the glue that holds it all together.
Asia is the behavioral health provider. She is a licensed social worker. As most across the country, most of the behavioral health providers and people doing collaborative care, most of them are social workers. Occasionally you'll have a nurse or a psychologist or a counselor, but most of them will use social workers.
You want someone who is outgoing, someone who is relatable to the patient population, someone who the patient can come to and they feel trustworthy. And so that's one of the key characteristics that we like in our behavioral health provider.
Asia's wonderful. She jumped right in. She is very good with the patients, and that's critical. Someone who interdigitates well with the rest of the primary care team and is the sort of person that the patients feel they can talk to, is reliable, friendly, and can connect people. So it takes just the right person to be able to do that. If you're an HIV patient with a mental health problem, finding a medical home that you're comfortable with is a big deal. And so bringing that mental health care to that clinic, I think is huge for many patients. They simply won't go get it elsewhere, but it makes a difference.
There's a lot of patients with mental health needs that weren't previously getting met. And so being able to use this intervention has opened our eyes up to the different ways that we could meet the needs of the patient.